Hi everybody, this is Dr. John Pitts of the Centennial Schultz Clinic. Today I've got an interesting topic. I want to talk to you about treating cervical degenerative disc disease or discogenic pain, disc-related problems in the neck region using PRP and bone marrow concentrate. These treatments can help disc tears heal and help improve pain and function. And I'd like to share a recently published data with you on that. This would be a good presentation for both patients, general public, and providers alike. I don't have any financial disclosures to disclose, and this is for information and educational purposes only. This is not specific medical advice for a particular person or patient. So what I'd like to go through today is just briefly touch on some of the prior cervical regenerative medicine research that's been out there, the intradiscal technique that we developed, share recently published case series data, and offer some conclusions based on all those. So we have a few published papers that relate to regenerative medicine and treating cervical problems. I'll go into more detail maybe in another presentation, but briefly we have some evidence that prolotherapy treating ligaments of the neck can help with whiplash and neck ligament injuries and show improvements and instability in the neck, and that can in turn lead to improvements in pain and function. Our group has also published a paper on utilizing PRP using what we call a functional spinal unit approach, where instead of traditional pain management where you just try to target one or two specific structures that might be causing pain, we target multiple areas of dysfunction that are contributing to an overall problem in the neck. So that can include the joints, the nerves, the disc, the ligaments, the tendons, the muscles, etc. So a more comprehensive approach. And that has been shown as a small case series to be helpful for pain and function. There's been some research in just doing PRP to cervical facets for facet joint pain that has shown some help. Also in the cervical and lumbar regions using platelet-rich growth factor injections are similar to PRP, showing some benefit. There's some research in cervical PRP for radiculopathy, meaning treating nerve issues in the neck that cause pain, numbness, tingling, or weakness down the arms. And then there's a paper that's just comparing orthobiologics like PRP to manual therapy and physical therapies to see which one wins out, and PRP was in the higher group for improving pain or function. Now, as far as specific publications regarding injecting orthobiologics inside the cervical disc, we have two case studies, both by Dr. Stanley Lamb. This is the first one he published, where he treated a 58-year-old female that had disc-related pain in the neck, C6-7 area, and radiculitis. So what this means is have pain in the neck, usually lower part of the neck or upper part of the back. The pain can radiate down the arms, may have some numbness or associated weakness. The typical first line of treatment is physical therapy. So all these patients, this patient failed that type of physical therapy. And he did an ultrasound guided injection, confirming with fluoroscopy or x-ray guidance into the C5-6, C6-7 disc, and perform what we call a discogram, which is basically having the patient a little bit awake, where we can say, hey, does this reproduce some of your typical pain in this region? And if so, we know that's a disc that's likely to be causing a problem and needs treatment. So he did PRP that was maybe 5 times baseline concentration. It was leukocyte poor, meaning less white blood cells, so that can mean a little less inflammation. He did put a little bit of lidocaine into the PRP to help with pain, but lidocaine can have a little bit of toxic effects depending on the dose. For this patient, the average pain went from 6 to 8 out of 10 down to 0 to 1 out of 10 at 3 weeks. The patient had improved range of motion and overall reported 20% functional improvements in being able to do more things. So pretty good, but just a one patient case report, which is great. He had a second case report, this time a 52-year-old male, similar symptoms, similarly failed physical therapy and medications, actually had a laminotomy, which means removing of some bone to open up space around the compressed nerve from a disc that's protruding outwards, irritating that nerve. That whole surgery, which is a much bigger deal than injections, helped the strength only, but not much as pain and function. So again, this patient went intradiscal injections at C5-6, 6-6-7, similar PRP preparation with a little bit of lidocaine. And at 2 months, had a 50% reduction in their pain, um, and sorry, a 50% reduction in pain in 1 month and 90% reduction at 2 months. His functional scores improved significantly. So the higher on this neck disability index, the more disabled they are. So they went from 28 to 5 at 2 months. And at 9 months, the pain was down to 0 to 1 out of 10. No weakness and just some mild stiffness. So significant improvements from that. So I'd like to talk about just cervical intradiscal technique. So traditionally, there's been no kind of technique out there described besides those two case studies that show how do you inject into cervical disc for orthobiologics. In the past, people did injections for discography, meaning just a diagnostic injection to see if that disc produced typical pain. That procedure could have, some risk of infection and lots of pain with it. So it kind of grew out of favor in determining which patients might be candidates for surgery. Back in the day, they would just use a landmark guided injection technique where they just kind of pull some of the vessels apart manually and stick a needle into the disc, just kind of by palpation alone. So obviously a lot more risk with that. And so I just kind of developed my own technique to get into the disc. And so basically we come from the front side trajectory. We use a combination of ultrasound and fluoro, so we always know exactly where our needle is. I like to use ultrasound so I can be sure that we can avoid the carotid artery, the jugular vein. And sometimes you can also use an alternative approach when that approach doesn't work just on the patient's anatomy, where you do go through the thyroid, but you want to avoid the thyroid artery and the carotid artery. And then I'll use X-ray to help guide the needle as well and confirm. We inject a little bit of contrast to confirm that we're in the disc with X-ray because you can't, see what you're injecting on X-ray. You have to confirm that what you're putting in is in the spot that you want it. We also put a little bit of gentamicin in the contrast, which is antibiotic that can help to reduce the risk of the most common infection inside of disc. And we were using bone marrow concentrate, and we use a leukocyte-rich PRP. 16 to 20 times baseline concentration, so a very high dose of PRP. And we like the leukocytes just because that can help further prevent risk of infection. And at the same time we were treating the disc, we also would treat any damaged facet joints, ligaments, tendons, muscles, etc., as needed based on the patient's history, physical exam, imaging, so treating the whole functional spinal unit. So this is a paper we published. So me and Dr. Markle, my colleague at the clinic, two physicians that kind of used this technique, and these are patients that were in the study. And we had our research partners, Dustin Berger and Aaron Dotson, help put together statistics and helping get things organized, and part of our clinical research team collecting data and helping to analyze that data. So big thank you to those guys. So here's a picture of just the needle technique. So on this view, the top is the front of the body, or anterior. The bottom is the posterior, or back towards the back of the patient. Anterior lateral means this side is the front outside. This is the medial or inside part. And here we can see the thyroid, the carotid artery, the jugular vein, the nerve roots that come out here. And then here we have muscles. So we have the needle coming in below the vessels, going through the nerves so we don't hit the nerves directly. We're going in between them, going through muscle. This is the vertebral body, so we have to go in between the vertebral body where the disc is and guide that needle into that area. So now after we got the needle on the ultrasound, we use X-ray to kind of finalize the trajectory, or fluoroscopy. This is a lateral view where we can see the needle going directly inside the space between the vertebral bodies. So that's where the disc is. The middle part of the disc is the nucleus. So that's where we aim. If there's any tears in the annulus, typically you'll see that contrast flow into the outer portions of the disc as well. And we always confirm in two views, both the lateral and AP, to make sure we're in the right spot. Here's an example of what contrast looks like when it flows into a tear of a disc that's sticking out. So you can't see disc on an X-ray, but again, they're between the bones, and when you inject the contrast, this black substance, we inject in here, but that contrast flows from the nucleus into the annulus, and we can see that annulus is sticking all the way out into the spinal canal, and so this is where it can irritate some nerves. We can see it zoomed in on this picture where we have a disc that's sticking out, even slightly extruding upwards with this disc. So it has a pretty big tear in it. And this is from a post-surgery patient, which is very common after surgeries. You get extra stress above and below the surgery site. That's called adjacent segment disease, and that can cause damage to the disc above and cause some pain and symptoms. So how do we select the patients to be injected for this study? Basically, we're trying to select patients that we felt had discogenic pain. So usually on history, this is patients with deep, dull, aching pain, just kind of sitting around, lifting things, twisting, heavy lifting, straining. Usually the pain is periscapular, and we'll show you kind of what I mean by that around the shoulder blade area. Sometimes we'll have pain going down into the arms, again, numbness, tingling, maybe some weakness. The MRI shows a tear in that disc with a bulge or a protrusion, meaning that disc can stick out some. And it's not just a normal, hey, we get older, the disc is just kind of getting some dehydration and losing some height. The patients had neck pain and radiculitis, and they failed kind of conservative treatments, meaning medications, physical therapy, other non-injection based treatments, chiropractic maybe, etc. Didn't have a diagnosis of craniocervical instability, which can mimic a lot of symptoms of lower neck problems. So we just kind of took those patients out for the study. And we wanted, we track all our patients in the registry, so we want to make sure those patients at least filled out all the information we needed for at least 3 months of outcome data. So if you're wondering what's a typical pain from a cervical disc, so if we think the neck is up here, the pain is usually below where the actual disc is. So it doesn't hurt exactly in the spot where the problem is. This is a good paper by Cloward that showed when you inject into the disc, where did that pain refer to? So the C4-5 disc was kind of just above the shoulder blades. I'm sorry, the C3-4 disc was just above the shoulder blades. The C4-5 disc, 5, 6, 6, 7 were all in between the shoulder blades type of pain. Sometimes if the disc is torn or sticks out on one side versus the other, you have a right or left predominance. But these are the typical patterns for disc pain. Now, of course, this can sometimes overlap with joint-related pain in the neck as well. So you want to make sure you rule that out either by, joint-related pain is more extension-based. It can be kind of achy as well. And you can also do injections to show if it's coming from the facet joint or not. And so if those fail, it may be coming from the disc. So when we look back over a course of a couple years, we treated 52 patients intradiscally. 18 of those patients met inclusion criteria, meaning they didn't have craniocervical instability at the same time, and they filled out their registry data basically. We wound up with 5 females and 13 males, and the ages ranged from 33 to 73 years of age. 10 of those patients we treated with bone marrow aspirate concentrate. 8 of those patients we treated with leukocyte-rich PRP. And so we always, characterize what we're injecting. So the bone marrow concentrate is basically a concentration of your bone marrow. You get rid of the red cells, and you're just left with the cellular portion. Has a lot of blood-derived cells in there, hematopoietic stem cells, white blood cells, platelets, etc. So you can get what's called a total nucleated cell count, which is a proxy for the number of stem cells in that sample. So the higher the number, the better. And so a good number is maybe about 400 million, for an aspiration. So most of our patients were pretty high in that range. And per injection or per cc, we had about 244 million was the range. We injected about half a cc in a disc. So about 126 million of those nucleated cells were injected on average into the disc. For PRP, we use a lab processing, so we can customize our PRP. So we did a leukocyte-rich preparation because, again, we want to be able to fight infection more, prevent the risk of infection better. We use 16 times baseline concentration, so highly concentrated. And the platelet dose in a half cc was anywhere between 1.2 to 3.6 billion as an estimate if these patients had a low to normal platelet count. Leukocytes were about 4 times the typical baseline. And the measurements we used were basically numeric pain scale, what level of pain was decreased, FRI scale is a functional assessment of how much activity a person can do based on the spine. And then the SANE, which basically is the percentage improvement that the patient themselves reports to us. I got 10% better, 100% better, 0% better, etc. Now, all these patients also had multiple other neck issues going on, so we just didn't treat their disc. We also, perhaps if needed, treated their posterior neck ligaments. So these are examples of injections into supraspinous, interspinous ligaments, the VDL, the PAUM, and the nuchal ligament. These are examples of treating the ALL, or anterior longitudinal ligament, in the front if there was instability. Again, supraspinous, interspinous ligaments. A very arthritic and difficult C2-3 facet joint, a C1-2 facet joint, and a lower facet joint. So just some examples that we treat the entire cervical spine, any issue that's having a problem. So we're not blanketly just treating every joint or every tendon, every nerve, but we pick out the areas that are causing problems and make sure we are thorough in treating all the ones that are problems for that particular patient. And that's called that functional spinal unit technique. So here are the results for those 18 patients in this case series. We got a follow-up minimum of 3 months, max of 2 years. The average was about a year. 14 out of 18 patients had at least 6-month follow-ups that they recorded in the registry. There were no adverse events, so no real issues, problems, infections, anybody needing to be hospitalized, or any damage to any structures. The numeric pain scores had the kind of smallest reduction. 9 decreased in NPS score. 7 had the same pain, and 2 pain might have increased a little bit. 30% met the minimum clinically important difference, meaning about a third of the patients had a significant amount of pain reduction. A lot of these patients didn't have a lot of pain as their number one complaint, so that's why these numbers are a little lower. It was more functional deficits that were a problem. A lot of these patients also had been treated before they got that pain down. So by the time we were treating that disc, it was more about improving the pain a little bit more or improving function better. The FRI was a functional improvements. We had 14 of the 18 patients improved, 65% meeting that minimum clinically important difference. So a significant number met a lot of improvements in function. And if you ask the average improvement that the patients said they had, the average was 43% improved after this procedure, and 89% of those met the minimum clinically important difference, meaning that improvement was significant for them and made a difference in their lives. So here's this information just kind of in graph format. So we had a lot of patients that had little pain. So for those, they pain might have gotten a little bit better, but that wasn't the big drop. For the patients that had higher pain scores, they tended to lower those pain scores. And there was just a couple people that didn't respond, and maybe their pain had went up a little bit over time. So again, 7 out of 18 had reduction in pain. And this is just plotting that out, how much pain reduction they received. So more patients improved their function over time. And so on this scale, the higher score, the more disability, the lower the score, the better. So we see most of the patients decrease that score, meaning improvement in function. Again, 65% of those were above kind of what we consider a minimum amount to get a significant improvement. So these are these patients here that made that difference. But most of the patients were getting reduction in their function, FRI score, which is improvement in their function. So now this is asking the patients again, what's your overall improvement that you rate on a 0 to 100 scale, even if you got worse. So 2 people didn't get any better. Everybody else improved above kind of the baseline. And we see at 1 month, we got a significant amount of improvement. And most patients continued to improve further at the last follow-up, which could range anywhere from 6 months to 2 years. So increasing improvements over time as we're initiating a healing response, and that can just get better and better over time. 13 out of 16 patients that were reported got greater than 50% improvement in their overall improvement score. So this is great preliminary data. But this is a small case series, 18 patients, but this is the largest case series so far utilizing orthobiologics for cervical intradiscal procedures. We didn't have a control group, so this wasn't a controlled trial, meaning have a placebo type of procedure to compare it to, because some of the effects could be due to placebo. This wasn't prospective, meaning we didn't start the study out beforehand. We went back and looked at our patients retrospectively. Again, it wasn't just isolated to just disc-related symptoms, because a lot of patients we see are more complex or kind of represents more real-world patients, but it wasn't kind of isolated to just one single problem that's better for study. And then we also use either PRP or bone marrow, two different injectates for the disc, so hard to know which one works better, which one might be providing more benefit. We also didn't just specifically test the platelet counts in these patients, but again, we can estimate the platelets based on normal values if we just assume on the lower side to be conservative. And again, multiple treatment targets, so we injected in multiple areas, so it's hard to pinpoint which particular injection may have helped them the most. But again, most of these patients in the study had already had PRP to the functional spinal unit minus the disc, so this is basically repeating some of that with the disc included. So in conclusion, since cervical discogenic pain is a very difficult problem to treat, traditional pain management treatments don't always help out. It's not a lot of pain management for the disc that can be done. Surgeries are a drastic, last resort option, which can have a lot of risk, even though it can be helpful. If you are going to do this, you want to come up with some innovative treatments. You're going to want to do a full spinal functional unit approach, utilizing some good quality, high concentration PRP and bone marrow concentrate. And of course, we need more study. This is an advanced procedure, so it has to be a really experienced practitioner. We've kind of developed this technique, which is similar to the technique Dr. Lamb published on. We have promising results, mostly 70% success rates, meaning patients improved function and had greater than 50% improvement in their overall subjective improvement. For this particular case series, we didn't demonstrate a ton of pain relief just because a lot of patients had already had some pain relief, so it was more about improving the overall functionality. Again, we use high concentration PRP and bone marrow concentrate. We need some larger controlled trials, compare it to placebo or physical therapy or steroid injections or functional spinal unit without intradiscal. So obviously this takes a lot of time and resources, so we'll try to publish as much as we can, but if anybody else is out there that's interested in research, feel free to help on out. If anyone has any questions, feel free to leave those in the comment section. Like, share, subscribe if you like this. Take care and thank you for watching.